This elderly gentleman had recurrent and fluctuating left-sided symptoms. Though his power was normal on arrival, he had weakness involving the left lower limb with a power of 3/5 and neglect. The left ICA injection showed ACA leptomeningeal collaterals to the right MCA territory and ECA ophthalmic artery collateral. It is important to note that if more collaterals are recruited, i.e. ACOM, PCOM and the ECA ophthalmic collateral, then it is a poor perfusion status. Leptomeningeal collateral certainly means that the perfusion is grossly impaired and this patient would need intervention. With the supraclinoid ICA filling, both petrocavernous ICA occlusion secondary to ICAD and dissection were considered. However, this typical rat tail appearance was suggestive of dissection involving this segment of ICA. Initial debulking with an aspiration catheter was performed with flow arrest using a walrus balloon guide catheter. Following the initial debulking, you notice the patency of the artery with a true lumen and a false lumen. It is important to traverse this segment through the true lumen and therefore a microcatheter and microwire was used to go across. Thereafter, the 014 wire was exchanged with a stiff coronary, soft tip wire and sequential balloon angioplasty was performed with proximal flow arrest. In the acute setting, we moved to injectable GP2B3A antagonist. A bolus is followed with an infusion and then changed to oral drugs as mentioned above. Thereafter, a 7x40 mm wall stent was deployed across the dissection, making sure it covers the proximal as well as distal end of the dissection. Therefore, the three key messages are: in patients with fluctuating symptoms, it is important to get flow information either through perfusion imaging or get a DSA performed. Leptomeningeal collaterals indicate very poor perfusion and more the number of collaterals also indicate the same. Finally, stenting in the setting of acute stroke with GP2B3 antagonist appears to be safe.